So healthcare, the Trump administration. One of the things that we saw immediately when Trump took office were a number of moves that affected how we utilize our healthcare. The biggest among these was HR 1, or the One Big Beautiful Bill for America. The frustrating part for me has been, I spend a lot of time in policy and insurance. There's a lot of noise on both the left and the right. And what's actually really happening with this bill is somewhere in the middle. So we're going to go through a couple provisions of the bill, kind of what it does, what it doesn't do. And I'll take any questions you guys have about the bill itself or anything else that's going on kind of policy insurance wise. So in case you have been sleeping for the last few months, on July 4th, the One Big Beautiful Bill for America, or HR 1, was signed by President Trump. This contains 331 pages of text. I've read them. They're really boring. If you need sleep aids, grab it. It's fun. There's a lot in this bill. It is not completely a healthcare bill. This is a reconciliation bill. The reason they were able to get it through is because they did it through the reconciliation process. The important part about that is it did keep some things out of the bill. There were a couple things we'll talk about as we get further in that were actually removed from the bill because the parliamentarians said that they could not be done in a reconciliation bill. That said, it did impact Medicaid, Medicare, and the marketplace. So before we go into how it affected Medicaid and Medicare, I'm not going to spend a ton of time on Medicare today because the effects on the Medicare program itself are a little bit more complicated and specific to each person's situation. But Medicaid does have some pretty large overreaching changes. But before we can understand how that affects us, we have to understand how we get our Medicaid. So there are two ways to get Medicaid. You've got the original Medicaid. This is your over 65, blind, disabled, or receiving other benefits from SSI, Social Security Administration. These are all people that fall within the federal poverty limit and these categories. The important part, and this is where most of our patients fall, is in this medically underserved category, or medically vulnerable category. If your medical bills are significant, you could fall in medically vulnerable list. Anyone who's dealt with hemophilia, bubble brain disease, any of our bleeding disorders, those you're going to get there really quick when your average medication is about $40,000 per month. When President Obama signed the Affordable Care Act, he added the Medicaid expansion. So this expansion population said, okay, not only do these groups of people qualify, but anyone who is under 133% of the federal poverty level qualifies, applicable to their family size. This is important because HR 1 does not change those patients in original Medicaid. The work requirements, the 6-month redeterminations, the things that have kept me up at night as we were watching this bill kind of progress, do not apply to this category. Those are specific to the expansion population. So if you are on Medicaid because of the Medicaid expansion, those things apply to you. If you're sitting in the original Medicaid category, these are not going to apply to you. Now, it did affect our immigrant population as well. So there are two categories when you look at Medicaid, Medicare, any of the federal programs. You have qualified immigrants or non-qualified immigrants. Effective October 1st, the definitions for these two changed. This was one of the biggest pieces regarding immigrants in the bill, is really changing those definitions. So lawful permanent residents, those who currently carry a green card, you're still fine. You're considered a qualified immigrant. Certain Cuban and Haitian immigrants, or those in the U.S. through a compact of free association, and lawfully residing children and present women in some states. This is again where the states have a little wiggle room. Remember, Medicaid is a state and federal partnership. So while there is a federal piece, the states also have their own money that goes in, and they have a little freedom there. Unfortunately, we did drop some. If you see the starred categories that were here, undocumented aliens were never covered under the federal Medicaid. There are states that, Illinois is one of them, that offer coverage for those people. The federal government has never paid any towards those. Refugees, asylees, DACA recipients, and abused spouses and children, were previously considered qualified immigrants. As of October 1st, they will no longer be considered qualified and they will lose access to Medicaid. So again, federal Medicaid match unchanged for the qualified immigrants. The states still get that federal match. But, and this is also not changed, no federal funds can be used for unqualified or non-qualified immigrants. We just changed the definition. That's where you see that savings. Now, this is the federal Medicaid match. There's also another program called Emergency Medicaid. This is where an undocumented immigrant or anyone comes into an emergency room. The federal government does provide coverage. They actually provide a higher FMAP, which is a federal matching medical assistance percentage. So typically the federal government pays 90%. Here they're paying a little bit more. This is eliminated in the One Big Beautiful Bill. Again, that's effective October 1st. There's another thing that's been in the news a lot is a state trigger loss. Illinois has one. So a state trigger law says that if the federal match, that FMAP, goes below 90%, the state who has taken on the expansion, this is specific to Medicaid expansion, will then eliminate that expansion population for coverage. These are states that have trigger laws currently. So the yellow, these are Medicaid expansion states with trigger provisions. The blue, these are expanded through constitutional amendments. There are no trigger points in these states. Medicaid expansion states with more flexible trigger provisions are in the light yellow, and no trigger is in this dark blue. And then your gray are states that did not expand Medicaid. But again, the one thing, and this got knocked out, this is one of the things I said got knocked out because of parliamentary rules, it does not decrease the FMAP. So it was in the original bill that went through the House, but it did get knocked out. So these state trigger laws at this time are not affected. There has been some talk about when the FMAP changes for that emergency Medicaid, does that cause the trigger law to start? That hasn't really made it through the courts yet. So we'll have to kind of hang tight and wait and see what happens with that one. I don't think it's going to. We also noticed a lot of changes in the marketplace. So right now, more than 20.
And for everyone's sake, and maybe a little bit of mine, remind everyone what the marketplace is.
Yeah. So the marketplace is created by the Affordable Care Act. The marketplace is where you could go out and get an individual plan. They are in different tiers, bronze, silver, and gold. The bronze plans being your cheapest catastrophic care plans. If you have a chronic disease, you should never be on a bronze plan. Then you have your silvers and your golds. We'll talk a little bit more about those categories and what's called silver loading in a little bit. But right now, 21 million people in 2024 signed up for coverage through the Affordable Care Act marketplace. It's not insignificant. 92% of those qualified for the advanced premium tax credits. So this is a credit you get from the federal government to purchase your insurance through the marketplace based on your income. They're reconciled the following year. When you file your tax returns, you're going to tell the federal government how much you made, and they're going to say, okay, you either still qualify or you don't. Prior to the One Big Beautiful Bill for America, there was a limit. You could not have to pay more than a certain threshold, and it changed each year back. So if all of a sudden you had gotten, say in January, you got a premium tax credit, in March you get a great promotion at your job, and all of a sudden you're kicked out of that 400% of the FPL, you would have to pay some of that back. But it was capped. That cap was eliminated in HR 1. So now if you get a really great job in the middle of the year, you've been relying on premium tax credits, you will have to pay some of that back up to what you would no longer qualify for. The other piece of this is this advanced premium tax credit was scheduled to expire at the end of 2025. As of today, it is still set to expire. It did not, a couple versions of the bill had an extension of the tax credit in it. It was one of the bargaining points that Congress was using. It did not make the final bill. That said, September 4th, we did see a bipartisan group. It was led by Jennifer Kriggins of Virginia. It introduces HR 5145, and it is to extend the advanced premium tax credit. Right now, it has 20 co-sponsors. The important thing is you're sitting 12 Republican, 8 Democrat. The original sponsor is a Republican, so you're sitting right now on the bill with 13. But as of last night, it has been assigned to Ways and Means. It's currently sitting in the Ways and Means Committee, but a vote has not been scheduled. So once it goes out of committee, once it gets a committee vote, it will then go for a vote on the floor. It has to get called for vote and go through their process. Again, I think this gets done because I think there's so many people understand how this is going to impact the marketplace. This will upend the marketplace and people's access to care. And that's not from the conversations I've had with Congress on both the Republicans and Democrat side. Everybody agrees we don't want people to lose access to care unnecessarily. So what didn't we see in this bill? But we probably will see a couple of these by the end of the year. Codification of ICRAs. Does anyone know what an ICRA is? This is a really horrible acronym. It's an individual coverage health reimbursement account. So as an employer, I offer coverage to our staff, health insurance coverage. We pay a portion of the premium. They get healthcare. They pay a portion of the premium. Function this we're all used to. We really saw ICRAs come out 4 or 5 years ago. Employers face considerable increases in those health insurance premiums. So if you're on a fully funded plan, it's not uncommon to get a 20% increase. So employers are struggling, especially the smaller employers, to afford health insurance for their employees. So the ICRAS started. What this does is it allows your employer to say to you, I'm going to give you $15,000 to go purchase your own plan on the marketplace. It is still ACA compliant per the regulations right now. There has been effort to codify this and actually put this in statute and allow these specifically through statute, because statute is going to leave it up to less challenge. That did not get through. It was in the original bill, did not make it through. These are really, really popular with employers lately. When I go to employer conferences, this is all I'm hearing about. Is the employers are saying, you know what, if I have an ICRA, I can limit what I'm spending for my employees. I can still give them access to health insurance. And the idea, this is what they're sold because I've heard it from brokers. If you have an employee who's healthy, they're going to purchase a bronze plan. Everybody's happy, you're saving money. If you've got an employee that needs more, they can put more in to get the higher plan. I don't think they understand how chronic diseases work and how we don't have a choice, but this is how it's being sold to employers. So they're still accepted in regulation. They're not currently in statute. I think this happens by the end of the year. So we talked about the different levels of plans. So you've got your bronze, your gold, and your silver and your gold. That advanced premium tax credit that we talked about is based on the price of a silver level plan in the marketplace. So what insurers have done is they do what's called silver loading. So they put the majority of their premiums on that silver plan. Your gold plan is still more expensive, but it's not as much of a delta as it could be, because they really want to focus on that silver plan to maximize the amount of premium tax credit that people can get. Makes it easier for people who want to purchase up to that gold plan. They don't have as much of a cost share. The original version of the bill that got approved by the House of Representatives included a limit on these CSR payments that match. It was intended to stop that silver loading, to stop incentivizing insurance companies to make those silver plans more expensive so that the others didn't have as much of a change. The Senate, this is another one that got kicked out due to parliamentary procedure. This is because of how, on a reconciliation bill, if it doesn't affect the budget, you can't do it. So the Senate's parliamentarian said this doesn't hit the federal budget. It can't be in the bill. I do think we see this come back too. I think there's a lot of appetite to end that silver loading. The government's trying to find savings, and they're saying it's not right that these insurance companies are forcing us to pay more money. So that's really fun for a Saturday afternoon. What can you do? There are a lot of ways in the next few months that you can, if you feel strongly about this, get involved. One of them is advocate to your congressman. I'm in DC at least twice a year speaking with our legislators throughout the area that we serve. Our patient stories drive change. We have gotten laws created. And you remember the Skilled Nursing Facility Act that we got created with Congressman LaHood. That was specific to a patient story where we explained the challenges that a severe hemophilia patient had in getting skilled nursing. Those stories are more effective than anything I can say. So please, if you're passionate about this, if you want to know how to get hold of your legislators, please reach out. I can connect you. We have connections with all of these offices. They do really want to hear these stories. If you anticipate changes in your insurance coverage, I cannot say this enough. Please call our office as soon as you know that something's changing. You may not have all the information, you may not know what plans are available, but the sooner we know that your insurance is potentially changing, the more proactive we can be on making sure that you know everything you need to find the best plan for you. I look through insurance plans all day, every day. Marsha, our social worker, does. We actually are hiring an insurance navigator for the sole purpose of helping our patients navigate the crazy that is insurance. So use your resources, please call us. There's nothing worse than you come in to get an infusion or an injection and we find out you have new insurance, because I can promise you that almost every insurance with the drugs that we deal with will require prior authorization, which means I can't do it same day. So please let us know if you think that it's going to be changing. And know your insurance. Know what your coverage is, what your limits are. Do you need prior authorization? Do you need approval to see a specialist? The more you know, the better. Again, if you have any questions about your insurance, grab your insurance booklet, bring it into the office, email Marsha. She'll reach out to me. We'll go through it and we'll give you a synopsis of what you should know in the plan. This is how we're here to support you. That's all I got. So if you have any questions?
Go back 2 slides. So just, and I don't want to assume anything about what everyone knows and doesn't know, but even for my own clarity, you were talking about the sort of an idea to for the government to sort of intervene with legislation to end this silver loading sort of thing that insurance companies are doing. But you were talking about it in the context of the marketplace, which is government funded, right?
Well, the marketplace isn't government funded. The premium tax credits are government funded.
Right.
Yes.
Exactly. So maybe just clarify like how those two interact. You have private insurance companies sometimes managing state or state funded healthcare. And then you have this marketplace that was sort of like in this space between what's private insurance and what's subsidized insurance by the state.
Yeah. So the marketplace exists differently in each state. The federal government rolled out healthcare.gov, where you will access the federal marketplace. Each state had the opportunity to roll out their own marketplace if they wanted to. These marketplace plans are run by private insurance companies. But if you remember the slide where I said 92% of people who get coverage through the marketplace get a premium tax credit. So they're getting federal funds to help them purchase insurance from those private companies. This is where, if you kind of step back and say, what is Congress thinking? This is where the appetite is to stop this silver loading, because they're looking at a private company. It's not the government that's doing that. It's a private company that's getting funds from the federal government to help you pay for your insurance. So the federal government is saying, why should we be subsidizing these private companies to make more money on the government's back? Now, is it short-sighted? Potentially. Is it going to cause access issues? This will absolutely cause access issues. If I look at what keeps me up at night, it is not the changes to Medicaid. Again, like I said, most of our patients who are on Medicaid are on original Medicaid. They are not going to be affected by this. Those who are in the expansion population, we can work with them, we can find other options. But one of the options for the expansion population is to go to the marketplace. These marketplace changes are what keeps me up at night. And yes.
So making sure I understand, does that mean that if silver loading ends, that like all plans might increase?
Yes, they will.
The cost?
There's no, they absolutely will increase the cost.
Will that like include, sorry, my brain just froze. Like if you have an insurance plan through, like a spouse's, employer?
Employer insurance? Yes and no. Directly, no, but I can tell you the way insurance works, it will. Indirectly it will, but it won't. There's not a direct correlation where it says if this goes up, this will. I just think you're going to see it go up across the board because when less people can afford insurance, they have less people buying in, so they raise the price for the people who can't and will pay. You have a question? Say one. Yeah, I think there are a lot of changes coming up, and one of the other things that I don't touch on in this that we're working with the federal government on is the alternative funding issues. And if any of you have sat through my talks in the past, I've spent a lot of time talking about this. This is where if you have a self-insured employer plan, so larger companies, actually any company over 50 employees can do it, but it's more common in larger companies, they can self-insure. So they say, we're going to take the risk of paying all of the premiums or all of the claims up to a certain point. At certain point is covered by reinsurance, so they pay a smaller amount for an insurance carrier to say like, okay, we'll take claims over 300,000.
So up to a limit.
Yeah, up to a limit. The employer is directly paying those claims. What we've seen is a lot of employers, again, the cost of everything are increasing. There's no one's arguing that they're not. Employers' response to that has been swayed by some of these brokers who are coming in. And the brokers will come into the employer and they'll say, you have 300 patients on your, or 300 members on your plan. You have 2 patients with severe hemophilia. If you carve out coverage for hemophilia, you're going to save $2 million this year. For an employer, that's an attractive option, especially for an employer. We see this a lot in the 50 to 150 employee groups where really that one catastrophic claim is going to upend your plan. And so employers are able, because these are not governed by the Affordable Care Act, they're governed by a retirement law called ERISA. They're able to carve out coverage. They say, you know what? There's no coverage for hemophilia. There's no coverage for orphan drugs. There's no coverage for any specialty drug. I've seen all kinds of iterations of this. You will see those increase as these costs keep going up and all of these changes happen. I think we see these increase. The good news is we've had some success with the government, both in the Biden administration and now within the Trump administration. We're working with the Department of Labor, the Federal Trade Commission, the actual administration themselves, our Congress people. So there is work being done on that. But if you are in an employer-sponsored plan, it is good if you understand, are you looking at a self-insured plan or a fully funded plan? Fully funded plans are the ones that are compliant, ACA compliant. Those self-insured plans, yeah.
Obamacare.
Yeah. If you look at your insurance card and your employer's logo is on that card, you are looking at a self-insured plan.
And remind people what percentage of plans, private plans, are self-insured.
68% of employees that have employer-sponsored coverage are a self-insured plan. Of those, 31% either already have alternative funding in place or are looking at it within the next 2 years. So if you have a self-insured plan, when your plan year comes up and it's time to renew, call the office. Let us help you work through it and see if any things exist in your plan. Yeah.
Will there be a specific person to help with that?
Absolutely. If you want to reach out to Marcia, our social worker, and she brings them up to me if she can't find it, and then I look at it. So yeah. Yep.
I was wondering, could you define what medically vulnerable means in Medicaid?
Yeah. So medically vulnerable is based on the percentage of your income that is consumed by your medical bills. So if you have a high medical burden, like if you have upper disease, hemophilia, and your drugs are so expensive that they take up, you may not be under that federal poverty level with your income, like on your tax return, but because of the cost of your medications, it actually does push you below that.
And so like my husband got a new job this year, and if he gets a promotion, we could be above Medicaid, but like with my daughter's medication, we could still potentially slide back because we'd be considered more medically vulnerable.
Yes.
Okay.
Yeah, and that's where we can help. Marsha can help you kind of navigate that if that comes up. I will tell you, employer-sponsored coverage, if you can get it, is sometimes better because it doesn't have some of the limitations that Medicaid does. But you can also have Medicaid as a secondary. So there are options if you do fall in that medically vulnerable category to kind of have both, and we can help you navigate this.
Yeah.
I will tell you the one thing I can never tell anyone is which insurance to pick. I will give you all of the tools and I will tell you what questions to ask. We legally cannot tell you you should pick this plan or this plan, but I'm really, really good at giving you a very clear understanding of what each plan shows. So if you call the office and you say, which plan should I pick? Don't get upset if someone can't tell you, well, this one, because we legally can't do that. But we can help you to understand what the coverage actually is and what's best for you.
And Becky, I think we have time for one more question.
Yep.
You want to take that?
Yep. Anything else? Okay. Yeah.
Let me just add too about the sort of the hazard of this alternative funding thing that's going on. Your insurance company may cover your blood disorder, the medical visits for it and such, like visits to a specialist. But you have to know if you or your child or family member is using a very expensive medicine, you have to know that your insurance will pay for that medicine. So sometimes it may appear like your blood disorder is covered, but the medicine may not be covered. So, and the medicine, when we look at like, what is the cost of living with hemophilia for a year, von Willebrand disease or thalassemia, where expensive medicine is used, the medicine is the largest part of your health care cost. So if it's not covered, it doesn't matter if you're able to go to a hematologist or not. If you end up having to pay for that medicine out of your pocket, I mean, sometimes it just can't be done. Some of those medicines are so expensive. So really know whether your plan has carved out, meaning excluded payment for those medicines.
Well, that's a really good point, Dr. Sheridan, because the way these alternative funding plans work and the way they're able to sell it to the employers is they tell your employer, your employee is going to get the same access to their drug that they've always had. We're just going to do it through the manufacturer's patient assistance program. So every manufacturer has a patient assistance program that's intended for uninsured or underinsured people. These plans redirect insured patients to those patient assistance funds. The challenge is that drug cannot be taken into the hospital. If you get in a car accident tomorrow and your plan does not have any coverage for your drug, that emergency department that you're taken into is going to keep you alive. They're going to do whatever is necessary to keep you alive, including giving you your drug. You are going to walk out of that emergency room with more death than you know what to do with, because you have absolutely no coverage for your drug, even in an emergency setting. That's what terrifies me about these alternative funding plans. So again, if you're concerned that one might be on your plan, if you don't know, if you want more information on what to look for, please call us. We're here to help. You know, Marsha's really great at looking through this stuff. We have lots of resources. Again, we're hiring someone, the entire intent of helping with this because it's gotten so complicated.
Now your plan's not going to have like bold letters, alternative funding. No, it's not. Those words aren't going to be in the plan at all. So you just have to like inquire or read or call whoever the a case manager for the insurance company would be when you call them to ask, is this medicine covered or not?
The best thing
it won't be in red. It won't be bolded, and it won't say alternative funding.
Now, the best thing is if you can get a copy of what's called a summary plan description, your employer is legally required to give you a copy of this. That is going to contain all of the language you need to see, charting what is in your plan. that's where we're gonna find that alternative funding. Matt has handed out these books that we created. This is just a little guide, helps you understand your insurance. It helps you as you're going into that open enrollment period. A lot of us are getting ready to come up on this in October, November. This will help kind of walk you through some of the questions that we ask when we're going through plans with patients. And again, if you have any questions about this or anything else, just call the office. We're here for you.